So this is the first case that I did, and what you're going to see along the way is this did not start off as a LOCATOR Fixed case. It started off wanting to do a screw retain full arch restoration, and then you'll see that the patient really couldn't afford to do that, and they decided that they wanted to do upper and lower snap-on types of prostheses. But there were some circumstances along the way that led me to not want to do a snap-on on the lower, and I was going to try to help her to go forward with some type of a fixed prosthesis. But at that time, Straumann came to me. They were working with Zest about doing some beta testing on LOCATOR Fixed, and so it was the perfect timing for me to do my first case and offer the patient something better than a snap-on type of denture. Now, the other nice thing about LOCATOR Fixed is that you can do digital workflows, you can do analog workflows, or you can do a combination of both. Some of the digital workflows for LOCATOR Fixed are still in the developmental process, but they're going to come really quickly. So those of you who live in the digital world and you want to get away from some of the analog, this is going to be very viable treatment workflow. But with digital, we can, advantages are we can sometimes do it faster because we're not shipping cases back and forth to the lab, we're uploading to the lab. The patient has the wow factor, which might convince them that you're the right place to be because you're, so up to date. We're eliminating cross-contamination. We can delegate some of these things to the staff that we maybe had to do previously. And in analog, what I found is our scanner still really for a full arch cannot capture all of the anatomical landmarks. You really, it's very rare that I see a scan that captured the retromolar pads, the mylohyoid, the mylohyoid areas, the hamular notches, and I like to have those landmarks when I'm planning my tooth position because those landmarks tell us a lot about where the teeth should be. I, being in dentistry for 35 years, I'm used to having an articulator with models that I can look at, I can turn around, I can put shim stock, I can use articulating paper. So for me, I like having analog models, but each day I am shifting more towards the digital workflows, and sometimes I use both of them on these types of cases. And with a analog, many times you have a little more control over the case. Some of the digital cases, you're going to get the prosthetic back, and it's just a prosthesis in a little case, and you're bringing it to the patient's mouth and don't know what to expect. When you have models, you can check it out. You can see which teeth are hitting. So both workflows have their advantages and their disadvantages. So here's our initial case. This is Rosa. She's partially dentate. The surgeon was Michael Shapiro, surgeon over on the west side. And we used both digital and analog workflows in this case. So the final result for this case is going to be a monolithic zirconia LOCATOR Fixed prosthesis. The impression technique we're using in this case is going to be analog, and the housing pickup is going to be indirect in the lab, which is done here at Rowe. And here's Rosa, and photographs are everything to me in terms of planning a case, because once a patient leaves and I'm doing treatment plans in my office, if I forget that patient's face, we don't know where the teeth should be within the face. And what we see with patients that either have severe wear or they've lost their teeth or if they have dentures that have sunken in, we start to see that downward turning of the corners of the mouth. That's called commissural droop. You start to see the jowl formation. And our plastic surgeon friends have figured out, what a beautiful face is, and it's usually equal thirds of the face. And so when you look at a patient like this, you can see that her lower third of the face looks a little short, and it kind of gives me an indication that she's lost some vertical dimension. And by restoring her vertical dimension, we can improve her aesthetics along with all the other benefits of function. And when you're doing your case workup and you're taking your photos, very important to get a full smile so that you can see where the position of the lip is when they smile. Because if you don't do that, it can fool you, and I'll show you a case shortly here where that was the case. And the way that I get them to have a full smile is I have them say E. I tell them, give me an exaggerated smile and say E, because when they say E, it activates those muscles. A lot of these patients have been so self-conscious about their teeth that even when you tell them to smile, they're just like giving you a little crack. So you got to do things to try to enhance them to give you a big smile. Another way is to take videos and start taking video, have them speak, and then say something just really stupid that just makes them crack up, and then they give you that, that big smile. And then you can take that video and take still shots from it so that you can give that to your lab for the planning of determining where that transition line is, so that we don't see where the prosthesis ends and where the tissue starts on a full smile. The side view is important because usually when the patient has teeth, it tells us if the teeth could be moved forward or backward. In her case, she's missing her front teeth or they're severely worn, so it doesn't tell us as much in that instance. So if we look in Rosa's mouth, she's got severe wear, obviously. And you can see that her lower teeth are actually crossed over her upper teeth. So she's got no posterior stop, she's got a collapsed vertical dimension, and she has an anterior hit and slide. So this is not centric relation, this is centric occlusion. And in these full arch cases, we have to take our records in centric relation. Because if you take the record in centric occlusion where they've slid forward 5 or 6 millimeters and you develop a prosthesis, you go to surgery, on the day of surgery, teeth come out, their proprioception is lost, their jaw drops back, their condyles seed in the fossa, and now you have a class 2 situation where the back teeth are hitting heavy with a wide open bite, and you're in this full arch surgery that the patient's been sitting there 4, 5, 6 hours, and now you're grinding the teeth in. And in surgeon's office, a lot of them don't even have a high-speed handpiece. They're using that surgical drill that's vibrating. So you want these cases to fall into place so you can shorten the time of surgery and give the patient a little better experience. So when I evaluate Rosa and guide her into centric relation, you can see that she hits that canine. And then as she closes, she slides down this inclined plane, hits the front teeth, and then the front teeth come even more forward. The other thing, that advantage of mounting these patients in centric relation, many times when you find that centric relation point, the first contact, that many times will give you the proper vertical dimension. I don't have studies to show that works, but having done this for a long time, usually something like that will give us a good indication and tell us where that vertical dimension should be. So in centric occlusion, she's a severe pseudo class 3, and you can see, because this has been going on for so long, that her front teeth, her upper teeth have been pushing her lower teeth out labally. So she's got these canted teeth, and we have to take that into consideration when we're planning her tooth position. We don't want to place implants based on where her teeth are now. We want to place implants based on where her teeth are going to be after we do our planning. She has some supereruption of the teeth that don't have opposing teeth. Inadequate posterior restorative space. Every once in a while, you get a patient that comes in with something similar to this, and the dentist has made a partial denture and hasn't addressed it, and you just kind of think, where's the thought process on doing things like that? And here's her radiograph. She has decay in many areas. She has shifting and drifting of her teeth. She has a periapical abscess. So all kind of things going on in Rosa's case. So the goals of treatment for Rosa are to restore her vertical dimension, reestablish facial third proportions, develop a physiologic occlusion and centric relation, and create an aesthetic smile in harmony with function. So from a medical legal standpoint, even when you know in your heart that that we should remove these patients' teeth, you have to have a different mindset, because some of these cases, no matter how bad it is, there could be a way to save these teeth and do crown and bridge or removable partials. And for me, knowing that not all patients are compliant, knowing that there's things that are not under control, like patient with diabetes or patient that disappears, there is a time when you do a beautiful full arch case and the case is going to fail. And in a court of law, I don't ever want to be sitting in front of a lawyer having him ask me, did you provide options for the patient to save her teeth? Did you tell her about what happens when you take the teeth out and you get bone resorption? Did you tell her about the risks of implant failure? So I want it fully documented that I provided a patient with the option to save their teeth, and I want it signed by the patient that they had this, because I want, in the end, I want them to be the one that makes the decision as to removing their teeth, not me telling them you got to get rid of these teeth. So if we were going to save Rosa's teeth, we'd have to do endodontics to create post spaces to build these central incisors up. We'd have to do post and cores and crowns. We'd have to do gum surgery for crown lengthening to create an increased ferrule for that crown to have proper retention. There's some areas of where she lacks attached tissue, so she'd need some gingival grafting. We don't want those teeth splayed like that. She'd have to have orthodontics, and is there really any anchorage to bring those teeth back? And then she would need a removable partial because the bone in the back is not adequate to place implants. And so then you ask this question: how much will it cost? How long will it take to go through all that? How many different specialists will she have to see? Can we guarantee the results? And when I discuss this with the patients, they're usually like, no, I've come to the conclusion I don't want to go see all these different specialists. So you're kind of, even though you know that's the right thing to do, you gotta kind of steer them in that direction. And then this treatment plan is scanned, put in my chart. It's there, so that if anybody questions what I did on this patient. Now, before I was introduced to LOCATOR Fixed, this was the options for full arch types of cases. They're either going to get a conventional denture. In the upper jaw, they would get 4 implant snap-on, because the studies and my experience has shown that 2 implant snap-ons don't work very well. The bone is softer. We tend to get more recession of the tissue, more bone loss, more failures. So I always do 4 when I'm going to do a snap-on in the upper arch. And then a 4 to 6 implant screw retained restoration. In the lower arch, we have an additional option because the bone is stronger, and we've seen historically that 2 implants and that nice dense bone in the anterior mandible can work very well. So there's 4 options for the lower arch. And this was the form that I would give the patient when they're thinking about what they want to do, so that they would know their costs. The form that I've put in your folders, I've added the LOCATOR Fixed to, but I wanted to show you where I was and where I am now. And I have this is a dentate treatment option. So whenever a patient's going to lose their teeth and they're going to have a removable type of an option, they're going to have to wear an immediate denture while those implants heal. We can't attach to the locators and pull the denture in and out, or those implants are going to fail. So any of the removable options, there's a fee for an immediate denture, and I make sure that they understand that clearly. For the edentulous patients, we don't have that immediate denture cost, and I think the one I gave you in your folders is for the edentulous patients. Okay, and so spoke about litigation. As a prosthodontist, I have the luxury of getting a lot of patients who have problems. They've had treatment, they're unhappy, and they hear that they should go to the prosthodontist. And when I'm seeing a patient and they're not referred by the dentist, and they're obviously looking to blame somebody, I never make assumptions that something was done wrong by that initial doctor, because I've seen myself how patients can be non-compliant, how they can do things that can change the course of treatment. And sometimes patients are so persuasive, they'll talk us into doing things that we don't want to do. So I'm always trying to protect that previous dentist. But I'm seeing a lot of people jumping into the full arch arena that maybe have not been trained adequately, or that want to do it fast and quick, and it's more just to make money and not to change people's lives. So there's certain things that you could do to protect yourself, and certain things that I see that cause these problems to happen. And digital technology, to me, especially for a lot of the younger people who don't know the basic prosthodontic principles, is kind of used as a crutch and causes them to skip steps. So we got to use digital dentistry as an advantage, but still know the basic prosthodontic principles so we can have great outcomes on our patients. Okay, so the first thing that I see that can cause problem is, well, the things you need to do to prevent these kind of problems is document the existing conditions, have great communication, present all the treatment plans to the patients, talk about the advantages and the disadvantages, talk about the costs, talk about the risks of not treating these conditions, and also to do a risk assessment, a very thorough risk assessment. And the communication that is so important is both communication with the patients and also communication with your interdisciplinary team, the surgeon, the prosthodontist, the restorative dentistry, the laboratory technician is part of the interdisciplinary team also. And it used to be that 10 years ago, maybe more, when we'd have a complex case, I'd call the surgeon, I'd call the periodontist, I'd call the orthodontist and say, hey, let's get together and work this case up. And we'd schedule a meeting, and the meeting would be at the end of the day, and half hour before the meeting, the surgeon would say, hey, I have an emergency, I can't make it. The periodontist would say, my son's got a baseball game I didn't know about, my wife's going to divorce me if I don't go to this. And these meetings would fall apart, and these cases, these wonderful complex cases that could really have a nice ending, end up sitting on your lab bench, just sitting there, and then the patient's calling and saying, when am I getting my treatment plan? But today we have all this great technology that allows us to talk together without being together, in a physical manner. So we can create these little virtual meeting rooms, and there's all these different platforms like Loop from Straumann, SmileCloud from Straumann, Dropbox. Rowe has a very nice system for putting all the information together. But we can put our photos, our digital x-rays, our STL files, our CBCT, all in a little room so that every member of the team can look at this, and we can plan individually and talk to each other to make sure these cases, work out well. Videos to me are the most important thing, because we get to see patients during their speaking, anatomical movements. It's really a helpful tool to help you plan your cases.